welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Hello and welcome to Brain Chat, everybody. I'm Dr. Mitzi, the nerdy neurologist, and I'm so excited to be here for another episode of Brain Chat talking about topics that are really important and affect not only the MS community, but the broader neurologic community. And I have got two amazing experts with me today, and we're going to have an awesome conversation about a topic that has really been hot in the news. Recently, we're talking about comorbidities in MS with a particular focus on obesity. For those of you who have not watched Brain Chat before, log into the chat. Tell us where you are logging in from. I bid you greetings from Atlanta, Georgia, where everything is green and the pollen is pollinating. So I hope that everyone is well, and thank you for taking out the time to view our show tonight. So we're going to bring up our guests, and I'm very excited about the ladies that I have with us tonight. They have both been on Brain Chat before, so they are Brain Chat veterans, but also international experts in their own right. We have Dr. Ellen Mowry, who is a professor of neurology and epidemiology at Johns Hopkins, and we also have Dr. Fatima Cody Stanford, who is an obesity medicine physician scientist at Mass General and the Harvard Medical School. Welcome back to Brain Chat.
Thanks for having us.
Absolutely. So I'm really excited about this show because this is the topic that has been talked about very recently. We've seen a lot of celebrities, particularly Lady O, talking about obesity. And I want to talk about this kind of in the context of multiple sclerosis and basically neurologic disease. But I think this is really important because we're learning about brain health and many of the behaviors and lifestyle modifications or things that affect our cardiovascular health also affect our brain health. But before we do that, my first question on Brain Chat is always tell us a little bit about yourself and how you got into your field of practice. We'll start with you, Dr. Cody Stanford.
Absolutely. Well, first of all, it is a delight to be here with you, Dr. Williams. I've known you for a long time now. I think we're getting into that 30-year realm, which is dating us a smidge. That's beside itself. But so, how I got into this field, one of the things that I really started to recognize really early, probably close to that 30-year realm, is that obesity was a disease. And before we were really recognizing it as a disease, I recognized that it was disproportionately impacting my community. And by my community, I'm talking about the Black community, and by my community, even more specifically, Black women. And when we look at this disease process, we do know that of all individuals, particularly here in the United States, that it disproportionately impacts Black women more than other groups. And so I, at that point in the 90s, was really intrigued by the fact that it disproportionately affected our community, but it really seemed to not necessarily preferentially impact us even by socioeconomic status. So you could be of high socioeconomic status and still be impacted. And so I really was curious about this. And so I wanted to begin to understand that. At that time, if we're looking at the late 90s, as I was really beginning to really delve into this, all I knew was to address this disease process by lifestyle, because that's all we knew, which was focused on diet and exercise modifications. I didn't really understand anything about pathophysiology. I didn't understand obesity to be a disease. It seemed to be a personal choice, a thing that you just got up and you did the work. You worked hard, you ate less, you exercised more. This is what we were taught to believe. This is what we were taught to think. And this was what we learned about. But as I began to study and to learn about this disease, I began to learn that this was a complex multifactorial disease process. And as I went through my training, which included residencies in internal medicine, pediatrics, and then eventually a 3-year fellowship in obesity medicine here at Mass General and at Harvard Medical School, I began to recognize that there was indeed deep pathophysiology that was
Mm.
affecting our storage of adipose, this organ that is fat, that was governed by our brain and our organs' abilities to communicate, influenced by
Mm.
different things that we're telling our bodies to store. And as I think about this interplay of race and racism and our this group that I was particularly interested in, particularly Black women, people that look like me, and recognizing our stress and stressors and the idea that we store more fat when we experience more stress and the chronicity of stress. And then I realized that the light bulb went off that, oh my goodness, when we look at the chronicity of stress that we experience for a variety of reasons, it would make sense that Black women who disproportionately are impacted by stress or stressors for a variety of reasons, whether it be due to race, racism, trauma of all kinds, would experience a higher predilection to larger body types. It made sense. And so that's what
Mm.
really brought me to this work.
Yeah, amazing, amazing. And we're going to delve a little bit deeper into that. But before we do that, Dr. Mowry, tell us a little bit about how you got into neuroimmunology and how you started doing work with comorbidities, among other things. You do a ton of research as well.
Yeah, thanks. Well, I started working with people with MS kind of before there were MS medications available, and decided this is a really amazing group of humans who, despite the fact that they don't have a lot of hope and are experiencing a lot of disability related to their illness, they maintain this great attitude and sort of positive outlook for the future. And of course, luckily, as you know, Dr. Williams, things have changed a lot for our community. A lot of people are living very well with MS. But in thinking about the relationship to obesity and related disorders, we also know that some people are still developing the slow accumulation of disability. And so now that I feel like we have a lot of great treatments for preventing relapses and what I call new spots in the brain, I really am trying to think with my patients really in mind about what are the best ways that we can help them prevent long-term disability. And as you know, we think that that is related to degeneration of nerve cells in the brain and spinal cord. And so as an epidemiologist, I've been really focused on trying to think about things that are intervenable, right? Like there are a lot of genes associated with MS risk and prognosis, but what are the things that we can act on now to help prevent that long-term disability? And that's where intervening on comorbidities that appear to be relevant and seeing if that helps change the outcomes is a major goal.
Yeah. Yeah. I mean, I think it's been so amazing just to see the advances in both of these fields simultaneously. For MS, now that we have more effective treatments and we can control relapses, we really can take a step back and begin to focus on other modifiable risk factors to see how these impact disease. Whereas before we were so focused on, stopping the acute neurologic changes, stopping the new MRI lesions, that we just didn't have time to focus on that. And we told everybody, eat a healthy diet, exercise, lose some weight, and you'll do better. And so I think we're really beginning to kind of pull the layers back and see, how does this really work and how does this affect brain health, right? So brain health is a really hot topic. And many of the behaviors that we think of as brain healthy are also the same behaviors that are heart healthy. Decreasing stress, which Dr. Cody Stanford touched on, can affect, obesity, as well as, weight loss, etc. So let's kind of laser in a little bit more on obesity. So I always learn a lot in these episodes. I am a person who has struggled with obesity my whole life. And it's so interesting, when I hear Dr. Cody Stanford describe, how we think of it as a disease, but growing up, it was not thought of as a disease. I was a child that people called healthy, which was a nice term for fat, or husky, which was my brother's term, and so it's really interesting to now see that there are biologic factors factors that are affecting that. So let's talk a little bit more. I want you to delve a little bit more, Dr. Cody Stanford, into kind of how that understanding has changed over time and how we now recognize that this is a condition that needs to be treated chronically, not just you go get a procedure and you're good for the rest of your life, or you do this for a certain period of time and you do that. Because honestly, the weight that I am currently trying to lose, I probably have lost 3 times in my whole lifetime, all of it. Of it. And then the next thing you know, 5 or 6 years later, it's it's back to where it was.
Yeah, and I really appreciate you asking this key question. And yesterday I was doing a lecture, and this key question came up, and so I'm prepared. I prepare often to answer this question. That weight loss doesn't equate to treatment of a disease, right? And so let's talk about this, because when we lose weight, we are dealing with hormones in our body. And I'm going to talk about this. I'm going to get a little scientific for a moment, but I have to go there just to help people understand why weight loss doesn't mean we've treated the disease that is the chronic disease that is obesity. So we have some key hormones. I'm going to call out a few of them. Don't worry, I'm not going to go into all of them because I'm not going to teach my whole field in one episode, but let's call out a few of them. And we're going to call out the key hunger hormone in the brain, which is ghrelin. And for those of us that are old enough, at least 3 of us on the screen are, ghrelin, we're going to remember that. We're going to think about gremlins. You guys remember the gremlins?
Yes.
Gremlins were these ugly.
Vividly.
Right? But ghrelin is this key hunger hormone that we've identified, which is this, what we call orexigenic hormone. It tells us to eat. It stimulates our desire to eat. It's housed in our brain, but it's also housed in our gut, and it tells us to eat. It is a very fierce, annoying kind of thing, but it's housed in our brain and our gut, and it tells us and it stimulates our desire to eat. When we go on a diet, we can drop our ghrelin levels acutely. And so we're losing weight. We're thinking we're all good. We're like, hey, that ghrelin level dropped acutely. But ghrelin is a gremlin, and it's going to come back, and it's going to come back fiercely. Think about that ghrelin. It's going to come back. So it's going to pull you back. Ghrelin's going to emerge. It's going to pull you back. And so that weight that you were thinking was gone, it's gone for a moment, but it's going to come back because ghrelin is there. It's in your brain. It's not just a willpower situation. It's housed within the hypothalamus, and it's going to reemerge. It's housed within the gut. It's going to reemerge. And there are going to be these hormonal changes that are going to shift you back little by little. And then you're going to sometimes reemerge, and often reemerge at a weight that was even higher than you initially started when you went on that diet. And you're like, wait a minute, I did all this work. I don't understand. Right. And the work might not have just been lifestyle. It may have been a surgical intervention. It may have been a medication that you went on, what we call anti-obesity medication. And so when we talk about this chronic, and I'm going to use your terminology when I say you're the neurologist, and this is where I love your terminology, relapsing, remitting chronic disease that is obesity. That terminology you guys use, I'm borrowing that from you. I'm taking it. I'm going to make it in the obesity world. It's because it really indeed is. It needs chronic treatment. As soon as you pull back the treatment, and whether that treatment is lifestyle or if it's anti-obesity medicine or surgery, you have to treat it long-term, because you can't just do the acute thing, because those hormones are there. Ghrelin, that key hunger hormone. Let's talk about, I'm not going to go into the treatment. I'm sure you guys are going to ask about medicines later. Well, let's talk about GLP-1, not the medicine, but what's in our body. So GLP-1, which we're hearing in terms of an injection that I give someone, I don't think everyone knows that GLP-1, which is glucagon-like peptide 1 receptor agonist, is in all of our bodies. I may just have more of it than you, Dr. Williams. And so if I have more of it in my gut, I'm going to be leaner, because GLP-1s tell my brain to eat less and store less. So if I have more of it in my brain, I don't have to give myself an injection, because my brain by itself is going to do what yours may not do. And so if we go back to us as children, when you were healthy, my brain just already did more of that because I had on board more GLP-1. So when I'm giving my patients a GLP-1 injection, i.e. semaglutide, better known as Ozempic, Wegovy, or tirzepatide, which is a dual agonist, which is, we can get into that, another type of injection, I'm giving, and GIP is also in our bodies, that's another thing, but I'm giving them what they didn't inherently have as much of for those of us that were inherently lean. So when we blame them for taking something, what we're putting blame on them for not having what my body already had. But GLP-1 is in all of our bodies. All of us sitting here, anyone that's listening to us, it's already here. It's just that some of us were born with more of it than somebody else. And so when we go on a diet, also what happens is that these GLP-1 levels are affected, or if we have surgery. So let's talk about people that have bariatric surgery. Initially, ghrelin levels go down, so you're not as hungry. GLP-1 levels come up, which means you're feeling full. But the further you move from surgery, guess what happens? Brain kicks in. And the brain is like, wait a minute. Did Jane have surgery? Oh, wait a minute. I'm going to fix that. Those hormones start to reemerge. So those people that are feeling guilty that they regained weight because they're like, they did something wrong, it's not their fault. Those hormones start to reshift back to where they were. And when they start to regain the weight, they feel like, gosh, I did it. Oh, I'm so bad. I did the wrong thing. This is why one of my biggest areas of research has been using medications as an adjunct to bariatric surgery. So when you look at my surgical patients, you're wondering, why did they not regain weight? Because my patients went on meds after surgery, not immediately, but as soon as they started to tell me, hey, Dr. Stanford, you know what? I'm starting to feel hungry. Oh gosh, Dr. Stanford, as soon as they tell me those magical words, I've already guided them that before they went to surgery, hey, this is what's going to happen. So as soon as those magical words happen, I add that medication. And guess what? My patients double or triple their response to surgery. So people are wondering, like, why are they out here living their best lives? Why are they getting double or triple the response that everyone else is getting? It's because I know the science.
Right.
It's not their fault that they're regaining. They're not going to regain because I'm going to double or triple because I'm going to catch them before that happens. Right. And we're going to use the science to guide us. So what I'm here to tell you, Dr. Williams, is that wasn't your fault. The first, second, third, 10th time that happened, it was the science doing what science does, which is ghrelin driving you back, GLP-1 saying, nope, it's not going to happen. And us feeling, particularly as women, that I can do it. I can do this on my own. I'm supposed to be able to do it. And let me tell you why we feel that way. Because there is a small percentage of the population that can do it. Those big lifestyle responders, those people that, I'm not going to name some of those names because they're the ones that like to attack me on social media, but some of these people that may have been on big shows, that may have come on where people lost hundreds of pounds and regained all of their weight, that about 4% of those can lose large percentage. I won't name that show. Actually, I'm going to name the show, The Biggest Loser, where only 4% of them were able to keep off their weight, right? They went on a show, they lost large amounts, 4% of them were able to keep off their weight, 4%. So everybody assumes that, okay, I can be that 4%. What about the other 96% that regained all of their weight? So we penalize the 96% because their biology worked as most biology does. And then we lift up the 4% that did it the right way. So was the 96% wrong and the 4% right? Or were they a little bit just more abnormal in that their bodies just happened to work in that way? Do you see what I'm saying? So
yeah,
that's,
I mean, there's so many. So there's so many parallels, right, between obesity and MS. I see you nodding your head, Dr. Maury. There's so many parallels, you know. I think very similarly in this age of, wellness, healthiness. Everyone wants to be plant-based. I am seeing, more and more patients who feel like they should be able to control their autoimmune disease through healthy diet and exercise, and very similarly, I explained, in my 20-year career, maybe I had 5 people who, thank God they were okay. They ate vegetables and they turned out okay. But by and large, 95 to 99% are going to have more problems because that is their biology and that is the way their immune system works, and it's overactive. And no matter how many vegetables they eat, they can have another relapse because that is the way that their immune system is working and they don't respond to that. So we have very similar, issues, or very similar, concerns within the neurologic community. So Dr. Maury, I want you to take a minute and tell us a little bit about what we understand about obesity and how it impacts multiple sclerosis.
Yeah, super great question. And, I love coming on here because I always learn so much, really from the conversation. So, I think it's important to note when we're studying obesity that I think sometimes that construct of obesity, where we say if your body mass index is X, Y, or Z, we're going to call you normal or overweight or obese, needs to be challenged a little bit, right? And I'm not the expert here, but there are limitations in the way it's defined. And I'm not 100% sure that in MS, the thing we call obesity is the actual cause of the outcomes that we see. Like maybe it's obesity related illnesses, for example, that underlie like some of what we're measuring. But going back to MS, many studies have looked at obesity as defined by this body mass index. So looking at how your height and weight relate to one another, and suggests that carrying extra weight, and especially if you carry extra weight seemingly in like late adolescence, early kind of young adulthood, may be a risk factor for actually getting MS. And so that's been, that's kind of held up in several studies. And then we've looked at people with existing MS to see what happens in terms of their MS activity, and have seen in a couple of different cohorts that degeneration of brain cells, whether you're looking at slow degeneration on brain MRI scans over time, or at degeneration of the brain cells that make up what we call the optic nerve, which is the nerve that leads out to the eye and brings in all the sight, does seem to be increased in people at higher body mass indices. And so that's been, I think, a pretty strong signal across cohorts. We've also looked at other illnesses that can be linked to obesity, although can occur independently as well. So for example, in a very large group of people with MS, multi-site study, we looked at whether people had no, what we called cardiometabolic comorbidities. These are high blood pressure, diabetes, and high cholesterol, or if they had one or two or more of those, and showed that people cross-sectionally, meaning at one time point, who carried two or more of those comorbidities definitely had greater amount of degeneration of their brain cells, and also had worse performance on neurologic tasks, things like, moving pegs from one side to the other, walking, that sort of thing. And then over longer periods of time, we did see that carrying those extra comorbidities led the brain to degenerate faster based on an MRI scan. So again, that doesn't tell us, mechanism per se, or, what sort of thing. A lot of that seemed in the comorbidity analysis to be driven by particularly diabetes. But it does suggest, right, that those illnesses may have an impact on the health of the brain. And again, I'm not even sure that's MS specific. Studies in the broader population also show that those kinds of illnesses cause your brain to degenerate faster. But I always tell my patients, we got to take it even more seriously, though, because you have the MS there trying to cause some long-term damage. Plus, you have this other problem. We don't want those two things to add up. We want to try to control as many of the factors that are controllable as possible.
Yeah. And, I always tell people the MS is enough. We don't need anything else on top of the MS,
Accurate.
you know. But then when we get back to the thought of how to treat, you know, these chronic conditions, obviously weight loss, exercise is a great way to help decrease, you know, the severity of some of these comorbid conditions like diabetes, hypertension, etc. The difficulty is when you try to treat it, we run into so many roadblocks. So first, I want you, Dr. Cody Stanford, to talk to us a little bit about, you know, you touched on it definitely, about kind of how do we treat this chronic condition called obesity. And then, I think, what are kind of the downstream effects of that when we are able to treat obesity and control it effectively?
Absolutely. So, when we think about treating obesity, we have different strategies we can take. We talked about using lifestyle, and, for a long time, that's all we used, right? And if you were ineffective in using lifestyle, you were considered a failure, right?
Right.
You failed it, instead of us thinking about the treatment failing the patient, right? So
Right.
lifestyle.
And can we pause for a minute and talk about the fact that in medical school, we really don't learn anything about lifestyle. I think maybe my nutrition class was 2 weeks, if that. There were no classes about stress reduction. There were no classes about how people should exercise, when to start. So even when we're telling people and giving them advice about lifestyle, it's very broad because we don't know unless we go through additional training or unless we just look it up ourselves in our free time.
There's nothing. It's very funny. I think back to medical school, and I think about reading, this is when we actually got magazines. You remember when we used to get magazines at home, and, I would get Self and Shape and Health and all the things. And I used to think, I'd be like, oh, look at my magazines, right? And I used to be like, oh, I want to be the person that's the advisor. Now I'm the advisor solved, and I'm like, oh, I don't want to be the person. But the funny thing is I'm the key advisor for men's health, not women's health, which is another story for another day, but whatever.
Right.
Yeah, so you guys go look me up in men's health.
We will.
Whatever, there's that. But seriously, you're right. We didn't get much education. But let's talk about obesity. I actually published a study in the International Journal of Obesity and did this entire assessment of every country in the entire world to see what are we teaching medical students, residents, and fellows. I did everybody. What are we teaching about obesity? And the answer is we're teaching nobody anything. And there's no country that is doing a good job. You can't say, in Denmark, they're doing a great job. Let's look at Denmark. They're doing a great job. Or, wow, in South Africa, we can look to them. There's no country that you can go lift up and say, let's look at what they're doing over there. And let's look to them as a, example, right? So the problem is nobody's learning anything about obesity. So if nobody's learning anything, that's a problem. And the reason why that's a problem is that we have over 1 billion with a B, 1 billion people with obesity worldwide. And if you're like, okay, well, Fatima, I don't want to think about the rest of the world. I want to be US centric, and you want to narrow it in on just the US. We're talking about 140 million people in the United States alone. So we're talking about the largest chronic disease in human history that we're learning zero about. So that's problematic, right? That's problem number one. But let's come and look at treatment. So we have lifestyle, which you just said we learned nothing about, unless you went and got one of these magazines and you learned something about exercise or dietary strategies. So that's one component. If you failed treatment or the treatment failed you, then we learned nothing beyond that. Now we have, and actually anti-obesity medications, I don't know if you guys knew this, anti-obesity medications we started approving anti-obesity medications, or FDA started approving them back in 1933. So when we talk about this being a new phenomenon, 1933, none of us were around in 1933. That was the year my grandmother, who's no longer living, but that was the year my maternal grandmother was born. So they've been around for a while, but I want you guys to know this. Nobody, I was doing a chronology of the FDA and its approvals. Did you guys know that methamphetamine, yes, meth, was approved for the treatment of obesity here in the lovely United States of America from the 1940s, 1947 to be exact, into 1979 here in the US for the treatment of obesity.
Interesting.
1979. They pulled it off eventually for because it caused, there was a risk of addiction and high abuse potential.
You think?
Thought you know that. Anyway,
Fascinating.
but medications have been around for the treatment of obesity since 1933. Some of the ones we still use, which include phentermine, have been around since 1959. So medications have been around as a treatment modality. Metabolic and bariatric surgery is still a phenomenal tool that is very, very underutilized for the treatment of obesity. But, we put these things in silos. We say lifestyle, behavioral therapy, right? Which could be cognitive behavioral therapy, motivational interviewing with our psychologists, psychiatry colleagues is also a treatment strategy. A lot of people look at them in these individual arms: lifestyle, behavior, anti-obesity medications, surgery. But if we really look at patients, many of them have had this wide range of therapies. And so when we look at patients, particularly patients that have had a history of severe obesity, many of them have had a combination of therapies or are on a combination of therapies. What we're getting into the era of now, Dr. Williams, is we're starting to see the pendulum swing a little bit too far to the right. And what do I mean by that? I'm going to give you one patient, my very first patient I saw on Tuesday. I see patients on Tuesdays. This is a patient that's been with me for 11 years, started off with me at a starting weight of over 300 pounds, has lost 62.7% of her total body weight. I want you guys to wrap your head around that. Okay. Not half of her body weight, 62.7% of her body weight. What was her weight when she saw me? 112 pounds when I saw her on Tuesday. Right. Your face, Dr. Mowry, was what my face did when I was in person also on Tuesday when I saw my patients. I see a lot of my patients virtually, but I was in real life on IRL, you guys. IRL on Tuesday. So when I went and got her from the waiting room, I physically go and get my patients. And she's had a variety of therapies, which include room-wide gastric bypass, anti-obesity medications, behavioral therapy, work with our psychologists, our dietitians. Her BMI, it started, I can't remember the number, somewhere close to 50 BMI. And I'm not a huge BMI enthusiast by itself, but I'm just giving you guys some perspective. Anything over 40 is considered severe, so somewhere 50 something. And we were at 19.5, which is getting into the too low category. Yeah. So I said, okay, guys. So I said to her, I was like, okay, well, I think, okay, also, I don't know if you guys remember Ratatouille, the movie where you kind of mix stuff together. So I kind of a mixer of situations. And I was like, I think I mixed a little too much, you guys. I think I need to pull it back a little bit. Go back a little, add a little to something. And she's like, oh, no, I like it. Look at my six pack. And I was like, so I did it just like that. And she's like, and she's a health professional. And I was like, look, I think this is a little too low. You gotta pull it back a little. She's like, yeah, but then I said, let me explain some things.
Right.
Let me explain. And so and it's interesting because we're in a different phase now where I can potentially overcorrect. Here we have a 55-year-old woman, which means we're in the post-menopause phase. We have a potential for having undergone surgery, which puts us at higher risk for osteoporosis. We're post-menopause, higher risk for osteoporosis. White woman, higher risk for osteoporosis. On GLP-1, higher risk for lean muscle loss. We have a lot of things going on. So I'm trying to explain to her all of these risks. I am not just going for an aesthetic look. Yes, if you want to have six packs, that's fine. But I also have to pay attention to health and not causing harm, right? That's what we want to know. We do no harm. But we have an interest in thinness in our society.
Pause right there.
Right? We have thinfluence. Right? Our desire for thinness, which was never something I was ever concerned about getting you too thin. I'm having to now shift some patients into recognizing that we're overshooting. I need to bring you back. And so I had to have this conversation. You hear me having to kind of explain why. these are the reasons why I gave her 5. I need to bring you back a little. So I'm going to need to adjust this GLP-1 dose because this is a little too much for you, because this is a little overshooting. But you understand that this desire for thinness, this cultural desire for thinness, where you've always lived, she's leaner than she was when she was 10 years old. She's 55, right? She's like, oh, wait a minute, I've made it to the promised land. And I'm like,
And
yeah,
like, no.
Yeah, this is a little too much. But does this make sense that in terms of kind of explaining these therapies? So anyway.
Absolutely. Absolutely. And I think, again, when we think about the benefits of weight loss, it is not just about an aesthetic, right? It really is about healthy, right? Because there are people who are thin who are not healthy. There are people who look overweight, who are in excellent health.
That is key. I did a recent podcast with Sanjay Gupta. And this is exactly what I mentioned. And I coined this term. I said, Sanjay Gupta, I didn't say it like that. I said, Sanjay. So Sanjay, we're going to coin this term. And, I'll say this here again. I said, look, I want to not practice what I call street corner medicine. And you can tell I'm from Southwest Atlanta when I say something like this.
That's it.
Where we look at someone and assume that just because they carry more excess weight that they happen to be unhealthy, and that just because they're lean that they're healthy, because we need to look beneath the hood. And this is straight from my dad, right, where he focused on teaching me about cars, and I probably know more about cars than most guys. But when we look beneath the hood, I need to know what the inner workings are. What are your metabolic parameters? What does your cholesterol look like? What does your blood sugar look like? What do those liver function tests look like? What is beneath the hood? Because you can't judge the book by its cover. You can't just look at a person and just assume that because they're heavy, they're unhealthy, or because they're leaner, they're healthy. I mean, I just told you methamphetamine was a drug. So you could be someone that just uses a lot of meth and you could be lean, right? Like, I mean, does that make you healthy? Like, I mean, what are we saying? So
Absolutely
we really need to look beneath the hood, right?
Yeah, absolutely. Absolutely. And, again, I think one of the challenges is, as neurologists, particularly when we're treating multiple sclerosis, we treat many, many different symptoms, right? We are faux psychiatrists. We are GI medicine doctors. Sometimes we're urologists, we are physical therapy. I mean, we do all kinds of things because it's so multi-system involved. And so when we come to, the end of a visit where we've talked about your vision and we've talked about, and we get to lifestyle, sometimes it's difficult to know where to direct our patients, for good information and good health. What are some of your tips or strategies that you do, Dr. Mowry?
That's a great question. Thanks. I have found that, in this era of using the electronic health record, I actually plop those questions to sort of see how people are doing with their lifestyle health in the middle, so that it's not like at the end, oops, I ran out of time. And sort of embed the coaching surrounding that along with the question. So we really focus on healthy diet, as well as on getting good exercise and body movement and sleep health. And those are questions that I ask of everyone. I don't pertaining to this sort of under the hood, I think best evidence indicates that healthy nutrition, regardless of your weight or other things, for example, is good, right? Like, I don't want my, skinny patients eating Doritos is their main source of food any more than I do somebody who carries extra weight. So I don't think that that's relevant. And then for people who have concerns for components of metabolic syndrome, they have some concerning numbers for elevated sugar levels or A1C, obesity, things like that, I almost uniformly refer them now to an obesity medicine specialist on our team. I don't understand why we aren't deconstructing this shame/body image thing from just what is a medical problem. So I'm like, okay, you also, in addition to all these things, have another issue and you could use some help, and let's get you in sooner rather than later. And it's not about your numbers. It's about what right now seems to be an evidentially association between having these problems and your brain at risk. And we want to try to tamp that down ASAP.
Yeah, I love that approach. And so, Dr. Cody Stanford, give us your perspective, for instance, for our patients who are out there and maybe they don't have access to an obesity medicine specialist. Like, where do people start? There are lots of different medical people who claim to be obesity experts. There's functional medicine, there's integrative medicine. There are some people who are not physicians, who may say they are obesity medicine experts. So how do people kind of navigate this when they're really trying to get healthy? What is kind of, a best practice or thought that you would give to those who maybe are not at Harvard or Hopkins, but who want someone who actually knows what they're talking about and has been trained? What should they look for?
Well, first of all, there's really easy ways to find out if you have people that are certified. There are now close to 7,000 people certified throughout the country, and there's a place to go to find that out. You can go to abom.org, which is the American Board of Obesity Medicine, and you can actually search by city and state. It's not behind a paywall, so you don't have to pay to look and find out who those people are. If you want to work with people that are like dietitians and other people that are not just physicians, you can go to the Obesity Action Coalition. And there are over 80,000 people that are members of the Obesity Action Coalition. That's a wonderful resource for persons with obesity that want a group to just coalesce with and get other individuals outside of just the MDs, like Dr. Mowry and myself, that are obviously physicians at big academic centers. And you want to speak with those individuals that have some special certifications in obesity, in the dietetic field, and things of that sort. So that would be a wonderful resource to consider. There's also the Rudd Center, which Rebecca Poole runs, and they have some great resources and tools there that you can investigate. And so I would look through all of those resources and tools to get really valid information, to just look through and see, like, hey, wait a minute, there are some individuals that I can look to and get some great information. So I would start and use those resources. These are trusted, validated resources. And so I would start with those. But so I would say abom.org, the Obesity Action Center, and the Rudd Center. These are going to be some really trusted sources. So there are places that you can get this information from. And through those three resources, I think these are really great resources to start. You don't have to be at the big academic centers. And I recognize that does not reflect where everyone is. And I believe that you don't have to be at the academic or the big academic centers to get great care.
Awesome. Well, ladies, unfortunately, our time has quickly come to a close. This has been an amazing conversation, as always, with you too. So one question for Dr. Mowry, and then I want parting thoughts. Dr. Mowry, lots of my patients ask me, will my obesity medication interfere with my MS medication?
That's a great question. There's nothing to indicate that as a problem of which I'm aware, Dr. Williams. And as such, I kind of continue to monitor the same way that we normally do for folks with their MS. We do had a slight worry when we're looking at these newer GLP-1 receptor agonists, which sometimes can cause some slowdown of the motility of the gut. And that can definitely happen related to MS also. So we'll be keeping an eye on that. That being said, there was a recent presentation at one of our major meetings looking at the lived experience of people with MS taking these medications. And the numbers of people who had to discontinue the medication because of that were not really dissimilar compared to what's been reported in the large clinical trials. So I think that it's definitely a possibility, and I might be really careful about monitoring things carefully if somebody had a pretty substantial, already had a history of slow gut motility with their MS. But I think, as we talked about earlier, we're really seeing more and more people living well with their MS and not accumulating so many problems in early days. So that's when we kind of want to act on, medically meaningful obesity and its related illnesses are before things have started to get worse, in my opinion.
Absolutely. Excellent. Dr. Cody Stanford, what are you excited about? So 2 seconds, Dr. Cody Stanford. Well, actually, I'll start with you, Dr. Mowry. What are you excited about? And I'll give Dr. Cody Stanford the last word.
Well, I'm very excited about how we can partner with our colleagues in obesity medicine and in nutritional fields in general, but really to hone in on being partners in treating people with MS and other disorders where neurodegeneration is happening, to see, can we curb that degeneration and, put some further roadblocks on neurologic related disability by adequately addressing obesity and its related illnesses in time. People with MS are often diagnosed at younger ages. Some of them aren't even in the business of going to see their primary care doctors. So we as neurologists have a great opportunity to kind of step in and take a stand for not only treating the MS inflammatory disease, the relapses and new spots in the brain, but also to say, hey, we have another warning flag here. There's some other problems going on. Let's make sure that those problems get addressed as well.
Absolutely. Love it. Last word, Dr. Cody Stanford.
Absolutely. Well, I absolutely love what Dr. Mowry said, is that we have an opportunity and we're at a true inflection point to be able to address chronic diseases like MS, like obesity, but we are recognizing the intersection, the intertwining, the overlap in ways that we have not before. We've been in our own silos, right? We're over here as neurologists. We're over here in obesity medicine. We're over here in all of the fields. But now we're recognizing the interplay, the intertwining of all of these and how interconnected they are. And we're able to get out of our own corners and come together, work together synergistically to begin able to tackle these chronic disease. And here, using the words of the neurologist, to come together, that relapsing, remitting chronic disease of MS with that relapsing, remitting disease that is obesity. And when we do that together, we know that synergy will create the ability to actually have success.
I love it. And I could not say it any better than that. Thank you, ladies, for your time. Thank you to all of our Brain Chat audience. Thank you to the National MS Society for sponsoring Brain Chat. And for those of you who are watching, please go download, subscribe to our YouTube, subscribe on Spotify, Apple Podcasts, all podcast platforms, and we'll see you again in 2 weeks. Thank you.
Thank you, Dr. Williams.